Okay, all right. Today's November, what, 11th? No, I'm sorry, November 9th. And we are doing one of our in-service, and it's called Problems and the Needs of the Age. So basically, as we get older, we tend to lose a lot of our independent abilities, and we're going to talk about those problems and then what we can do for those residents. Okay, so let's talk about comfort in general as far as residents go. Um, when these residents are uncomfortable, what are some of the things that are maybe causing some of the discomfort and what we can do for these residents? Pain. So when a resident is in pain, we typically expect the resident to be anxious, right? Or maybe we don't expect it. Maybe we come in and the patient is has anxiety, restless, and we just think that the resident is having some form of behavior issue. And then we call the nurse and say, hey, you know what, she's kind of anxious. Let's give her, can we give her something? Right away we wanna look for psych meds. When in reality we should try to assess the patient to see what they're having an issue with. And the first thing we should be looking for is pain, right? What are some of the things that could cause this resident some pain? Let's just say that you're not familiar with this resident. The resident is brand new to our unit. And we try to figure out, well, let's figure out why she's anxious, restless, maybe she has pain. So what are some of the things that causes pain for resident? Surgery, right? If a new patient comes in, maybe.
Yeah, they said, like one of my residents,
Yeah.
when I did it, or then
Right.
I called the nurse
Right.
to assist the residents with some Tylenol.
So pain is definitely post-surgical pain is definitely an issue with residents who, who might need some of these pain meds, right? So don't jump right away to conclusion and say, hey, let's give this patient anti-anxiety just because they're anxious. Let's look for what the cause of the pain is. What's the root cause of this pain? Okay, so pain meds is one of them. So what are some of the things that we can give for this resident? Pain medication, obviously, right? To alleviate some of that pain. But also maybe just moving around that extremity that's in pain, assessing, calling even the nurse. Range of motion a lot of times will alleviate pain. Increased circulation, which means that maybe you need to get at the resident. Maybe she's just having a cramp, right? You have a patient that's kind of confused, times 1 or 2. Maybe they just came in, admitted, and they were at the hospital, had a lot of medication. They're going to be a little confused. And so they may not even tell you, like, hey, I'm in pain because of this, or I have a cramp. They're just going to be, restless. So ambulation, range of motion, pain meds, those are 3 things that we can offer to these residents to alleviate those pain. Also, patients can have chronic pain, back pain. They've had that for a long time and now exacerbated, maybe on a transfer to the hospital to here, maybe on a recent transfer from a wheelchair to a bed can exacerbate pain. And so, again, asking for pain meds instead of antipsychotics is going to be really helpful for these residents.
Because of their age, like me.
Right.
Transferring when I'm sitting like this,
Yeah.
when I get up.
Absolutely. Chronic pain, whether it's muscular, whether it's neuropathic, somebody who's got a history of pain is going to be anxious if they're confused. They're gonna show it by increased confusion, increased anxiety, restlessness. So going through those comfort meds is going to be important rather than these psych meds. Contraction is another one. If somebody was contracted, if a resident is contracted, and they're uncomfortable because they're contracted. So doing range of motion, again, range of motion is really important, and just overall movement, passive range of motion or active range of motion is going to be significant for these residents. We're just talking about comfort right now. This is, we have a couple more staff that came in. We're doing answering some problems and the needs of the age, and right now we're talking about pain. What are the main causes of pain? So also incontinence. If instead of, hey, this patient is uncomfortable moving around, let's give her some psych meds. Maybe check to see maybe they're incontinent. Yeah, they're wet. Urine. What is the urine made of? It's acidic, right? It's acidic. It's very painful. If you sit on that urine for an X amount of time, for an hour, 20 minutes, 30 minutes, maybe an hour and a half, some of these residents may be sitting there for 2 hours, right? So that's very acidic, and that's why the skin or tissue starts to fall apart. You have denuded skin, meaning that the tissue is sloughing. And so when you have this tissue, the top tissue comes off, there's nerves in there. Unless the sub-Q is out, unless the muscle is out, you still have nerve there, and you're gonna have a lot of pain with that resident. And so how do you exhibit pain if you're confused? You're gonna be restless, you're gonna be agitated. So check to see if they're incontinent, not only urine, but also impaction, constipation, that can cause a lot of issues with restlessness. Okay, but yeah, providing the right pericare, changing them frequently, repositioning, range of motion, pain meds, rather than psych meds, okay, when it comes to anxiety and comfort for these residents. All right. Basic needs, if not met, can cause agitation. So if you have a resident that their basic needs are not being met, like we talked about, maybe they're hungry, maybe they're thirsty, maybe they're constipated, maybe they're retaining urine, right? These are needs, these are basic needs that they need that can cause restlessness. And so if you don't meet those needs, these residents are going to be very uncomfortable. Okay, you're going to have falls, you're going to work more. You're going to do double your work just because this resident is confused and is going to be more restless. Instead of just saying, hey, let's take a look at what's causing this discomfort, right? So, a patient who needs to use the bathroom, a nonverbal patient can't communicate. So it's going to be really important to really assess these residents who can't communicate, okay? We talk about A&O times 4, A&O times 1. What does all that mean? We've talked about this before. How do you assess for patient who has orientation? 1, 2, 3, and 4. So the nurse says, hey, this patient is A&O times 4, alert, oriented times 2. Okay, person, time, place, situation. If you're talking to a patient that's a new admit, you're asking them what's your name, they know their name. That's 1, right? They're oriented to name, right? If you ask them where you're at, if they know Abbott Seeker or somebody for rehab, they not only know their place, they know their situation, meaning that I'm here for rehab. If they say, I'm in Bahamas, I'm taking a vacation, I'm gonna go home soon, obviously they're not oriented to situation and they're not oriented to place. Okay, so, and then ask them for a date, what's today's date, even month, right? If they know the month, if they know the date, if they know the year. So these are orientation is very important because you're not communicating to a resident and asking them, baby questions. They're gonna be like, hey, what are you asking me? I know what the dates are, but if you're talking to the resident, hey, how you doing? By the way, what's today's date? Just making regular conversation, right? That's gonna be important to figure out whether this patient is oriented or not. Okay, so that's basic orientation. That's how nurses talk back and forth on their communicating how the patient is doing. Water and food, as we talked about, patient could be thirsty, could be hungry. If they're not able to verbalize these, they're going to be pretty restless when they're thirsty. Okay, so offer fluids and then offer snacks. Also, one thing that we didn't think about is that if the patient is, they have a light, right? Our lights in the bed lying like this, and they have a light that's blinding down on their face, right? Mm-hmm. They could be restless if they're unable to communicate because that light is so bright. They could be restless because of that. So turn off the lights, dim the lights down. Those are just simple things that we can do for these residents to increase comfort, especially on your shift, knock shift, when they're just laying in their bed all the time. And then communication obviously is important. Just communicate with these residents. They're not deaf. As you get older, you don't become deafer. Okay, you just can't communicate as much. But like if you talk to them in a slower manner, and then in a slow manner with the right phrase, instead of yelling at them, because you think they're deaf or whatever, slow it down, and they may be able to communicate with you. That eye-to-eye contact is really important because that's how these residents are going to be able to comprehend what you're talking about. Okay, but if you have your back against them and the patient's turning the other way and you're communicating, obviously that patient is only going to pick up half of what you might have told them, right? So communication with the use of eye contact is really important. Get down to their level and slow down your speech, and that communication should improve between you and the resident. All right, what are some of the things that also the skin? The skin, what happens to the skin as you get older? They lose elasticity, right? So that's why you see a lot of these residents that have dry skin. It's likely from decreased fluids, but also because as you get older, you lose elasticity. And so when you do transfers, a lot of times you'll scratch their skin off. Okay, so be careful with transfer, I guess was what we're saying. So what are some of the things that we can do for patients that have thinning skin, loss of elasticity? What are some of the things that we can do as nurses, CNAs, to improve some of that integrity, skin integrity? Cream is important, barrier cream. What is it? Lotion. What's the difference between lotion and A&D? Why do you want to choose A&D over lotion?
A&D is
for the redness.
Okay, A&D, you lock in moisture longer. Okay, lotion is basically kind of just like water. It's good, it moisturizes your skin, but it doesn't last as long as, let's say, Eucerin cream. It's not hot. It's A&D is very effective for moisturizing skin because it locks moisture in. Okay, it's got petroleum in there. Okay, and it lasts longer. So for example, if you got a patient that's really dry, instead of putting lotion in there, grab some A&D and put some A&D in there because it's more effective. Okay, the thicker the cream, the longer that moisturizing.
Makes them itchy.
If you're dry, yes. If you're dry, definitely itching is an issue because you have a patient that comes in that gets admitted. They haven't taken a shower in 2 to 3 days. Guess what they're going to be doing? They're going to be itching, right? And then you increase the risk of skin breakdown because of bacteria that might be growing in there. And so any kind of skin tears, there's a risk for increased infection if you have a break in the skin. But showering two times a week is recommended in skilled nursing, but also adding things like A&D, cream is going to be really important, or ointment is going to be really important. Handle with care, obviously transfer, like I said, their skin is thinning, and so any bumps could cause bruising and skin tears. And so transfers with 2 people is recommended if needed. And also, if you see that it's red and you push down on the skin, right, and it doesn't come back to its original color, what is that known as? Huh? No. So let's say the patient has been laying on their side for 3 hours, right, and now it's red, right, and then you push down on it. This is how you check to see if the skin is going to break down soon. You have a patient that's unable to move, and you're supposed to be repositioning every 2 hours or more. And that patient's been sitting there for 6 hours, nobody repositioned them. Their skin is now underneath and the coccyx is red. You push down on it, it stays red. That means it's non-blanchable. That means that the tissue is likely to break down. So when you have a bone right here and you're putting down pressure on the tissue, there's no circulation there. You need circulation for those tissue to live, right? You start to die off, right? Right. So if you continue to put that patient on that same side, that's going to open up and that's going to be an ulcer, okay? And that's bad. That's significant in our unit, okay? And we know that these patients are having this issue because either lack of hygiene or repositioning. So reposition this patient, apply these, and assessment, right? If you see that it's red, tell your nurse. So that way we can apply some foam in there, or maybe apply some moisturizer, or maybe some berry cream on there. Berry cream is really good for.
Who will apply the cream?
The nurses will. The nurses. So that's another in-service that we're going to talk about later. Anyways, bed sores represent increased fluids, right? So what do we do with people? What do we talk about? People losing elasticity, right? Residents that are aging and losing elasticity, right? It's likely because you loss of fluids. It gets pretty dry, and now and you lose the elasticity also.
They're not eating. They don't drink.
Fluid is really significant. When you have somebody, that's why nurses go like this with residents to try to figure out if their skin bounces back. Go like this with your skin. It bounces right back, right? It's likely because you've been drinking a lot of coffee. No, there's been a lot of fluid. Any fluid basically will give you that good, nice bounce back to your skin. The resident who's not been drinking, their skin is gonna stay like this. You pull back on the skin, it's gonna go down slowly. And you know that resident is dehydrated, right? And what happens when that skin does that? You have a high risk of skin breakdown. So increased fluids, repositioning, cream, lotion, A&D, all that stuff we can do for these residents, right? But offloading, we haven't talked about offloading and elevation, okay? So offloading means, what does offloading means on elevation?
What is uploading?
Offload means to take the load off, right? So let's say the patient is contracted and is unable to move on their own. You offload, means you take that bottom there, put pillows in there, reposition on the side. Same thing with the heels, right?
Offload.
Elbows. So that's called offload. Okay, offload, elevation. Okay,
How about Mr. Sapin? They need to have a donut for his bottom.
So Mr. Safin is a different example. So actually, we won't mention names on here. So with him, just mention room number. With him, actually, because he's not eating and drinking, it's very difficult to treat that wound. And that wound is maintained. We try to maintain that wound, prevent it from breaking down, prevent it from infection, but there's no way to heal that wound because he's not eating and drinking anymore. Okay. He's still drinking a little bit, but like that, what's protein do? Protein is it builds muscles, right? But if you have a skin breakdown, and you're not eating, guess what? That tissue's not gonna build up. You need protein. If you're not eating, you're not getting protein. All right, so offload, elevation, frequently repositioning, moisturizer, fluids, as we talked about. Those are all really important for your skin, right? All right, let's talk about circulatory system. So as you get older, obviously the resident, again, your circulation tends to slow down. I mean, and you start to have buildup of plaque in your arteries, okay? And so when that happens, you have high blood pressure. Just because that hole where the blood travels, it gets smaller, and so that pressure goes up, okay? When the blood pressure goes up, you start taking meds, and those meds obviously have side effects. But
What they need to do.
so with people that have high blood pressure or low blood pressure, usually fluids and sodium goes hand in hand. Okay, so if you have a patient that has a high blood pressure and they're eating snacks all the time and they have sodiums on their diet all the time, you know, so it's like water's like this and sodium here. When you put water here, the sodium is going to come back. It's going to attach to that water. And so when you add more water, the sodium is going to attract more water. When you have more water in your system, you increase your blood pressure, right? So that's why they say don't eat too much sodium when you have high blood pressure, because that'll increase your blood pressure. Okay, and so when you want to decrease your blood pressure, they try to get rid of those fluids by taking diuretics. So avoid taking diuretics by decreasing those sodium in your diet. Okay, and so that's important. And then as nurses, we see these residents all the time. They come in and out, and they grab their snacks, these chips, and you got high blood pressure, and it's like, hey, you want to kick back on those, sodium on those chips or whatever. And those chips are just there. They're just eating it all night, all day, right? And so that could be significant. What happens also? We just talked about fluid and sodium. What happens? What's another issue that the resident can have?
Diuretic?
No, as far as circulation. So you have high blood pressure because you have a lot of fluids. What fluids? Huh? Heart attack. But what's another issue for residents that are taking in too much fluids and sodium? Edema, right? Edema. So you have a lot of sodium, a lot of fluids, and that fluid has to go somewhere. Where does it go? Not only increase your blood pressure, but it also has dependent edema. So meaning that you have edema in your lower extremities, even sometimes in your arms, right? And so now we have to try to offload those and elevate those lower extremities to bring the fluid back to your heart so your heart can pump it out and you can pee it out. So this is important. You have somebody who's got edema, increased edema. What do you think is going to happen when you have high blood pressure, increased edema, on that resident who's now laying there in bed? They might have shortness of breath a little later, right? So it all comes back to your heart, because now your heart is trying to get rid of this fluid and it can't because it's too much sodium. You have blood pressure, and now that patient is going to have shortness of breath. So, applying oxygen, increasing the head of bed up is important for these residents that are having circulatory issue. Okay. All right, let's talk about musculoskeletal. What are some of the issues we can face or we're dealing with resident who has issue with musculoskeletal? Okay, as the resident gets older, we know that you use less of your muscle. We know that if you don't use it, you lose it. So you have atrophy of the muscle, meaning that the muscle is getting weaker. And what does muscles do for our body? It provides support. And so if you have a patient that's not moving around, that's not doing range of motion, that's not doing RNA, you're going to have loss of muscle tissue, and if those muscle tissue is responsible for support, during transfer, this patient might buckle, this patient might not be able to walk, so you're going to have issues with gait, you're going to have an increase in falls. And so that's why it's important to really walk with these residents, do range of motion, so that way you can continue to increase this muscle mass for these residents. But protein is obviously another important factor. Eating and drinking is a significant factor, because as we spoke just a little while ago, protein is the building blocks of muscles, right? So increasing that diet and watching what they eat and increasing those protein is going to be really important. Okay. Yeah. So what's another important thing we don't think about as far as muscle goes, and it's a muscle, right? Is what's holding your urine and your bowel in your system. That's a sphincter that's responsible for muscle, right? So if you have a weak muscle, if you have a weak sphincter, you're gonna have incontinence. You're gonna have incontinence with not only bowel movement but also your urine. Okay. So what do we do for these residents that we need to increase their muscle their contraction ability for their, let's say, urine. They come in, they have Foley catheter, they take the catheter out, and now that sphincter is really weak, right? You're gonna have a lot of incontinence. How do we improve those sphincter in your bladder? Toilet program, right? Taking to the bathroom every 2 hours, and that increases your muscle mass in the sphincter, right? And so you have the ability to control your urine. You have the ability to control those bowel movements. And but Kegel exercise is really good for increasing and making those muscle tight, so that way you don't have too much of incontinence. Okay, toiling every 2 hours. What is the toilet program means? What do you do for somebody who's on INOs and all that and bladder training? What do we do for them?
Take to the bathroom every
Monitoring.
How often do we take them to the bathroom? You got it.
every 2 hours.
Every 2 hours, offering them and you're supposed to be offering them. Do you need to use the bathroom? If they don't, they do whatever. Take them to assist them, get them to the bathroom,
You don't want to
and
go
that
to the
helps.
bathroom.
Yeah, and then chart it. So you just chart it, right? But that's how you improve it. But that makes your life easier, right? Because if they're continent, they're voiding in the toilet, they're not voiding in their diaper. You're not changing as much, and you don't have skin breakdown. So later on, you don't have issues with any of that stuff as far as.
But they getting, what do you call this, lazy, like Mr. Lambert before.
Mhm.
They can go to the bathroom now, no more.
Yeah.
When you turn, oh, he
Yeah.
yelled this morning, he yelled.
Yeah. Well, we gotta assist these residents and encourage them to do their own independency, and if they're able to do it on their own, encourage them to do it on their own. All right, decreased mobility, atrophy. We talk about increased incidence of falls. We talk about that. If you have atrophy of the muscles, you have increase in falls. And so we also, what's the main thing we should do for these residents that we can do? I know you guys work NOC, but what can we do for them to increase muscle mass and so to decrease falls with transfers and ambulation, right? What can we do for them? Range of motion is one of them, right? But also what? Ambulation, RNA, right? Restorative nursing, and walking them around not only increases circulation, and we'll talk about circulation in a little bit, but also increases muscle mass and it prevents falls later on for transfers and ambulation. All right, nutrition, obviously we talk about protein. Make sure that you're offering snacks in the middle of the night. This patient is losing muscle mass. You wanna offer those protein snacks. All right, let's talk about hearing and vision. So we talk a lot about this, how residents lose vision, lose hearing. Just because they're getting older doesn't mean that they're deaf, right? So, but they do have that normal loss of hearing as you get older. So
Let's see.
talk to them in a slow manner. Eye to eye is going to be eye contact is going to be really important for them. But you can see the issues when the resident who is hard of hearing is that they might not be able to hear you coming or whatever, and also communicating with them, with a board or something, writing things down if they lost their vision. But just coming to them, communicating with them, and ask them what they need is going to be really important for somebody who's hard of hearing or has visual impairment. Communicating frequently. Digestive system. What are some of the issues that we have with digestive system? We kind of talked about it a while ago. What are some of the issues we have? Constipation, right? So what can we do for somebody who's constipated? Or to prevent constipation, what can we do?
Drink a lot of water.
Drink a lot.
Eat from juice and fruits.
Yeah, but what else can we do? The fluids and prunes and diet and fibers, those are all really important for constipation, but what's the main one that we want to try to get to? Ambulation. What does movement do? What does movement do? Movement do, when you have the resident moving around, you have increased peristalsis. So when you have moving and walking and all that stuff, you have movement in your stomach, and you can acquire a lot of that by moving around. So if you're not moving around, you don't have movement in your stomach, and a lot of stuff can just stops, and so you have constipation, right? But if you're moving and walking, it increases movement in your stomach, increases the flow of bowel movement. So yes, fiber, fluid, all that's important, but don't forget about ambulation and movement, okay? Because that increases peristalsis, which is the main action that we want in the stomach to get rid of these bowel. Heartburn. What can we do for patients to prevent heartburn after a meal, or right?
Give thumbs.
Good times, okay. Besides medications, we can wait maybe an hour before you lay him down after a meal, right? And also increasing that head of bed up. Put that head of bed up, so that way they can prevent heartburn. Difficulty swallowing, the same thing. What do we do for resident who, as you get older, obviously we talk about muscles and how it gets weaker. The same thing with your ability to swallow, right? These residents has their ability to swallow kind of decrease. So they are a higher risk for aspiration. Aspiration leads to pneumonia, and obviously pneumonia may lead to morbidity, more death. So what can we do for these residents who have difficulty swallowing? Make sure that they're up and head of bed up. If they're eating in their bed, make sure they're elevated their head of bed at least 45 degrees when they're eating. If you can, you get them up on the wheelchair. And then also, if they're having swallowing, you can do the chin tuck technique, where if you swallow, you tuck your chin in, and then you swallow. What happens is that if you don't do that, your esophagus is straight up like this, and you swallow, and the food goes right down. But if you make an L with your esophagus, you tuck your chin in as you swallow, you make an L, and you have better control of the food, and it doesn't go right down.
When I take
straight.
medicine,
Mhm.
sometimes I do like this.
What about straw? Do we give straw to people who have difficulty swallowing?
No.
No. Avoid
Not.
straws if possible, because what that does is that it just brings fluid in pretty quickly. So, people who have difficulty swallowing, obviously we have these different type of diet. You have your mechanical soft, regular diet. You have your puree diet. But not only that, you also have these residents that might have special liquid, right? You have your pudding thick, you have your nectar thick, you have your honey thick, right? So make sure you have the right thickness of fluid for these residents when you're dealing with difficulty swallowing. All right, and then what is this right here? Temperature, insulin, and then endocrine, pituitary, parathyroid, adrenal, pancreas. Some of the issues with the endocrine system, obviously, temperature, mood swings. Somebody who's diabetic, maybe. So we want to watch their diet. Again, increase fluids for these residents. We want to watch their weight gain. So a lot of times they have weight loss or weight gain. So it's important that we watch these. If you notice that there's a significant weight loss or weight gain, obviously you want to monitor that. Either they're not eating enough, or they're gaining fluids, and so and somebody who has a weight gain of 2 or more weight in a given 24-hour period is considered significant. Okay, somebody who's diabetic, obviously they're going to be a high risk for skin issues, right? Because somebody who's diabetic might have neuropathic issue where they might not be able to feel pain, and so we want to monitor the foot and the toes, because those are the areas where diabetic patients is going to have these bed sores or diabetic foot ulcers. All right. And then reproductive system, we're just going to go over real quickly here. So female reproductive system is a lot shorter than male, so they are high risk for infection for UTI. So providing good period care is going to be really important. And remember to wipe, obviously for females, you're going to wipe from front to back. And so for males, some of the issues they have is BPH, enlarged prostate. When you have enlarged prostate, and a lot of you males here, it's just common. When you reach a certain age and your prostate is enlarged, it squeezes the urethra, and so you have less urine coming out. And that's why you have retention. And then you have men that are using the bathroom frequently, and it's just a dribble here and there because they have enlarged prostate. Okay, so, but monitoring these patients as they go in and out of the bathroom, and also communicating with your nurses how often you go to the bathroom, maybe taking a look at their meds as far as the nursing view. And but fluids is another important thing. And then catheter. Catheter as a CNA, what do we do for catheter? Remember that when you're emptying catheter, you're using alcohol wipes. When you take the urine out, you wipe it with alcohol before you place it back in. Okay, also freedom bag. It's a form of respect. You have somebody who has catheter, make sure they have a freedom bag when you're pushing them around in a wheelchair, so that way you don't see the catheter. You see a bag, but you don't see a catheter. Okay, and you change these bags. How often you change the bags for catheter?
Who changed that?
Are we the one or the
No,
nurse?
the nurse.
You're right. It's gonna be the nurses. Let's see. You change the bag on the. Did you guys change the bag, the drainage bag, to the leg bag, right?
No, we only empty it.
Yeah, we can
Yeah.
we can change from leg
The
bag
leg
to
bag to the drainage
the-
bag. If somebody has a drainage bag in the middle of the morning or in the morning at
Yeah,
night,
and
they
at
should be on the
night.
drainage bag. Vice versa. If they're waking up in the morning, you shouldn't have really a drainage bag on that resident. You should have a leg bag, right?
Yeah.
So
Yours
unless
is
they,
like that.
yeah. So once a week, that's what I'm talking about. If you change those, you got to change those once a week. Okay, and don't sit there and have that same drainage bag for like a month, 2 months, and it's because then infection is gonna be significant. All right, let's go and fill this out. This form's here, and so this video is gonna be uploaded on YouTube. Okay, if you miss a video, it's right here. There's an instruction right here. You can watch it. You can come in early even if you want. You need to text me if you're gonna do overtime. And you do an in-service, and then note it on your time card that you're gonna do overtime. But watch the video on there. There's an instruction. Watch it here. There's a speaker right here. It'll play the video, and then you need to sign in over there and answer the questions and the test. By my office, there's a little packet. It'll tell you what you watch and the title of it, and so that's a way for you guys to get your CEUs. Okay. So right now I have 2 videos in there, and this will be the 3rd one.